to our webinar today. Dr. Li Jun is also my good friend, and he's one of the most popular and influential dentists in China right now. He's been focusing on the bone regeneration and the soft tissue management for many years, and we've known that he's also the founder for Bugu Elite Training and the Bugu Oral Bone Regeneration Center. He's also the founder for Bugu Oral Innovation Forum. And he's been the keynote speaker for 2025 Petersburg Bone Augmentation Congress and last year's DIO Istanbul Summit. And he's also won many prize for those competition, like the first prize winner of a bone augmentation section on the seventh BITC case competition, and also the top 4 finalists on 2024's EAO Congress video competition, and many, many other prizes. And he's very famous for his beautiful pictures and fabulous bone augmentation cases. So we are really looking on for his brilliant presentation. Okay, so right now, let me leave this stage to Dr. Li Jun. It's our showtime.
Okay, thank you, my dear friend. I will share my screen. Okay. Now, can you see my screen?
Yes, we can. Yep.
Okay, I continue. Good evening, everyone. Thanks for joining us today. My name is Jun Li from China. And it's great pleasure to part of the episode Spotlight video series. And tonight, I will share with you the purpose and the clinical strategies for predictable bone augmentation and to achieve stable bone gain with GBR. I hope my presentation will give you some insights for your daily practice. Now let's get started. Since my dear friend Dr. Yan have given me a candid introduction, now I will skip this part. To start off, I would like a brief introduction my workplace, the Kuku Dental, which was located in Guangzhou, China. This is our surgical room equipped with various instruments and devices because we have received a lot of the referred patients. And I'm lucky enough to have a wonderful team that can help me take all the photos, video recordings, as well as chairside assessments during the surgery. Therefore, it's all about the teamwork here. I would like to briefly mention the Kuku Elite Training Center is actually located in the same position, just next door to the Kuku Dental. We provide several courses, mainly focus on the soft tissue and hard tissue extraction. We've hosted numerous courses in major cities across China, such as Beijing, Shanghai, and Chengdu, and other cities, to name just a few. And our training program has received popular among the clinicians across China. And once the participants have finished all our course we award them the Kuku Elite Grand Slam. So it's about my training center. Now, because with the limited time, I will just give a brief introduction. Now let's focus on my topic tonight. If we want to achieve implant success, we have to consider not just the function, but also the aesthetical as well as long-term stability. This is our ultimate goal. However, if we want to achieve that goal, it's not easy because in your daily practice, we also face a wide range of complex cases. Like the slide shows, we're facing missing tooth to multiple teeth and even full arch bone reconstruction. Some cases are very challenging. Therefore, we need a careful planning and delicate execution. We also need the strategies. We need to figure out which approach is the most optimal and which bone augmentation is much more predictable. Here is the PANS principle. It's actually a manual modification to the PANS principle, to the PAS principle, which was proposed by Hong Wang in 2006. Now I will elaborate this principle for you briefly. The first one is P, which stands for the primarily with coverage. If we want to perform bone augmentation, we know that if we have to perform everything is perfect, for example, we have to achieve the adequate autologous bone particles, and we keep the graft stable and rigid. But the final step, when we decide to close the flap, we find this a little bit tension, but we ignore the data. We close the flap. After 2 weeks later, the patient come back. We find the graft exposure, the wound dehiscence. That's truly nightmare, both for patient and clinician. So although it's an initial step, it's very important. Next, I will move to the A, which stands for a genealogy analysis. When we perform bone augmentation, some colleagues want to make clear, do I need autologous bone chips, or do I need to travel cortical perforations, or do I need to add any growth factor into that material to boost also genealogy? The next one is the N, which stands for the no infection. We know that when we perform bone augmentation, we need to wait several months. During the healing phase, if the patient tells you, doctor, I feel uncomfortable, I have a sign of swelling, even worse, I have some suppuration, that's bad news, because you will lose everything, you have no chance to obtain the new bone. So we need to keep in mind to avoid any infection. The next one is the T, which stands for time. It's the brand new factors that are added to the PANS principle, because it's equally important. When we perform bone augmentation, a lot of colleagues just follow the same protocol. They only wait 6 months. However, if we follow different protocols, we know that we need to wait various time. For example, if we decide to perform sausage technique, according to the literature by Eastern Urban, they told us the average re-entry time is between 8 to 9 months. If we open the flap too early, the new bone will remodel in a rapid way. So it's a great pitch. We will lose a bone volume. Last but not least is the S, which stands the space maintenance, the space creation or stability. Because with the limited time, I wouldn't touch every detail. I only to focus on the S, the space maintenance. Because in my mind, I think it's the most factors if we want to achieve predictable bone augmentation. To start off, I will walk you through a clinical case. This is the old case, and this is a young lady with poor origin. Because the tooth 2 and tooth 3 was tracked several years, and since then she has received a removable denture, but now she was not satisfied with that restoration. He wants to fix one. Therefore, he come to a dental office. From the occlusal view, you can see that the contour has significantly collapsed. It's not an easy case. In affected region, it's not an easy case. It's almost a challenging one. To further examine the condition, so we took our CT scan. Now, according to the sagittal view, we can observe this narrow alveolar ridge, especially just like left edge. So it's is very, very demanding. The next step, we need to develop our treatment plan. At that time, I think the most popular method is the only bone graft or titanium mesh. However, at that time, 2017, the new book was released by Israel Rubin, the vertical and horizontal ridge augmentation. In this book, Israel Rubin have proposed a brand new technique. We all know that it's called sausage technique because it's mainly targeted for horizontal bone augmentation. Although this case is have a manual vertical bone deficiency, but mainly want to build up the horizontal bone defect. Therefore, I adopted that approach and follow the protocol. Full thickness flap was elevated. We can see clearly this narrow alveolar ridge. Then, followed by collecting adequate autologous bone and mixing with their graft at a different ratio, and we adding some liquid PRF to make it a block bone. Then we put this block bone into the bone defect and compact it gently to make it a good adaptation. The next step, we need to fix the bone graft. We use a large cartilage membrane with the help of several member types. We can stretch the membrane to keep it tight and rigid. Now, from the occlusal view, it's very like a sausage, all right? So this is a lot of colleagues who ask me, why is this technique called sausage? Yes, the shape is very like the sausage. The next step, we have achieved the optimal wood corrosion. And I need to wait several weeks. I wait 2 weeks. And I'm lucky enough when the patient come back, we have achieved a primarily wood healing. So I feel very happy. I even want to open a champagne to celebrate. The next step is wait. We need to wait several months because according to the previous, I have mentioned the pace principle. The time is equally important. Since I have to perform the sausage technique, I need to wait at least 8 months. So 8 months later, the patient come back. At first glance, I feel a little bit uneasy. You know why? Because you can look at the occlusal view. The contour has significantly collapsed. But I don't think that's true. So I decided to take a CT scan to confirm that condition. As this white line indicates, it's obviously going to collapse here. So we took our CT scan and we can look at it. The cross-section view is just like I have done nothing for this patient, except several member tasks. However, I have to show the case for all of you. I did perform the sausage technique, so I feel very unhappy. And I compared different X-ray. The yellow box indicates the initial situation, and the yellow box, oh, I'm sorry, not the yellow box. The green box indicates the post-op immediately. We can observe the bone graft shape is perfect. It's very nice. However, the post-op 8 months, according to the occlusal view, is just like have just a little bit bone gain. I guess our number probably only 5 to 10%. Therefore, we have a failure. We need to figure out what was the reason for the failure of this case. So I found out this picture. The left one is the social remove, and the right one is the post-op 8 months. It's look very clear. The contour collapse significantly. So, and it's all told us that was happened during the healing. And we need to make clear which reason that's lead of failure. Some colleagues would be say, is it because of the patient chronic infection, because the patient was poor adhesion at the first time. However, I don't think this is real causes, because according to this occlusive view, the gingiva looks like healthy. There's no any sense acute or chronic infection. So when you figure out the other factors, it's actually because of the muscle pressure. When you can imagine the scenario, when patients come back home, they were chewing, they were talking, they're smelling. All of these movements were exact pressure on the graft. Some guests might say, oh, you have performed sausage technique, all right? You have shown me the sausage is tight and rigid. Why it's not work during the healing? Don't overlook the detail. We use a resorbable collagen membrane. With the occurring the manufacturing, we know that they will lose the function and they will degrade within 6 to 8 weeks. After that, the barrier function and the space maintenance capability will fade. Since then, the bone graft is not hard enough. The fair to withstand the pressure from the ubiquitous oris muscle, Therefore, he will gradually lose the contour that we have of failure. To further elaborate this phenomenon, I will use several publications to back up my point. Now, from this literature, it's published in 2022. This study, they compare two groups. One is conventional GBR, the other is a sausage technique. And they also come to the conclusion, if you perform bone augmentation in the anterior region, the muscle pressure from ubiquitous muscle in the early healing phase will induce resorption. Let's move on to another publication. This publication, it compared different scenarios. One is the posterior mandible, the other is the anterior maxilla. It's totally different scenario. We know that if we perform bone augmentation, the anterior region is relatively challenging. So the author told us if the grafts of the non-reinforced membrane alone will result in sufficient bone volume. Therefore, the space maintenance is very important. And currently, we have many, many approaches from the sticky bone, the sausage technique, the bone core, the shedding screw, and the PTFE membrane, the titanium mesh, titanium barrier, bone plates, whatever. In some cases, I will show you some cases. If I perform extensive bone defect, I want to perform bone augmentation, I usually love to use customer titanium mesh because it's easy to fix and it can save a lot of chairside time. And we also can achieve predictable bone augmentation. The bone quantity and quality is perfect, all right? And this is another technique that I very love it, is the Curry technique. In China, we also we like to call it the BBA, the biological bone augmentation. And because it can, within 4 months, we can have achieved a very good bone quality. That's why I love perform this technique. However, just as every coin has two sides, we also will have the complications. According to various publications, the mesh exposure incidence varies from 5% to 50%. That implies this technique is highly technique sensitive, all right? And let me talk about the complications of autologous bone graft. They still have the complications, the bone graft exposure, the bone graft infection. So if we encounter that complications, it's truly nightmare. So if you want to act this advanced technique, think twice. And here I want talking about how to choose different technique. For me, I think you should consider two factors. Number one is the case selection. The patient's general condition, the patient's compliance. And number two is the clinician's the scale set, or we call it learning curve. If you are very confident in to handle and deal with all kind of complications, okay, you're right. You can go ahead. You can choose a much more advanced technique, like such as the titanium mesh or Curie technique. That's my advice for all of you. However, I think some of you may worry about the complications. So in clinical practice, the typical GBR is predominant approach for the majority cases. In my daily practice, I think the incidence is overweight, 70 to 80%. And the next question is, some of you guys may wondering, is there a specimen tunnel that with a less technical sensitive, meanwhile with a good specimen maintaining capability? Yes, I will show with you. It's actually the tenting school. Now, I will review the history of tenting technology. It's actually proposed by Max in 2002. The first case is called the tenting pole technique. The first case perform extraoral incision and use several implants as the tenting pole to support the membrane to provide space maintaining. So this is the approach. And this publication also use this technique. However, because of the poor aesthetic outcome and no predictable effect, currently this technique is not used anymore. I think it's not predictable. So with the development of the tenting school, the tenting school technology, more and more clinicians will adapt tenting school instead of implant as a tenting pole because it's high risk. If you have the encounter the horizontal pressure, it will gradually lose control. Some you are not lucky enough. The threads of the implant were exposed. That's a terrible thing. So in this case, the Barry and the colleagues use the tenting school backwardly together with the GBR procedure. And finally, they can achieve a predictable bone augmentation, and they come to the conclusion this technique is saving time and cost effective. Then move on to another publication. This publication focuses on the horizontal bone augmentation, and he gets the bone gain is about 4.2 millimeters. This data looks like promising. Let's move on. The different scenario, the vertical bone augmentation. In this case, they had the average intra time was 9 months, and the average bone gain was 6.2 millimeters. Meanwhile, the explosion rate was only 0.8%. This looks like this technique is less technical sensitive and can have achieved a relatively predictable bone augmentation. And this is another publication. In this publication, is have achieved the average vertical bone gain was 9.7 millimeters, almost 10 millimeters. However, in my opinion, this publications and the vertical bone deficiencies looks like relatively favorable vertical defect, because the bone defect is narrow, is V-shaped or U-shaped. It's not extensive, it's not distal vertical bone defect. So I think it's easy. It's easy cases. Now, let's move on to the first question. What kind of tennis school do we need? To answer this question, I conducted a Google searches. Now I got those results. I divided into two categories. One is with bigger header and a thicker header. It's called the umbrella school. The other is with tiny header. Is typical tennis school. Which one is best? For me, I think both of them is not good enough. It's not optimal choice. You know why? If you choosing umbrella screw in your bone augmentation procedure, this screw will take up your space, increase the tension release. It become much more difficult. If you want to switch the tennis screw, because of the tiny header, it cannot provide excellent space maintenance. So both of those is not perfect. Therefore, we need a change game. Now, I have the developer 3-in-1 box. We call it GBR all-round toolbox. It actually contains three type of the fixation tacks. One is member pins. The other is the macro screws, and the last one is the shedding screws. Is very special one, because we have to provide a much bigger head, and we also have the several holes in the head. It can provide us much more vascularization during the bone augmentation. We know that the angiogenesis is very crucial, all right? So I have the good space maintainer when we perform bone augmentation. And the number two question, how should the tennis screw be placed? So we also found a classical publication. In this literature, they told us the tennis screw should be placed vertically to the basal bone on the crease aspect. However, I will elaborate further use the illustration. If we place the shedding screw like this, look at this. The yellow box indicates the bone gain in the crystal aspect is not enough. If we perform implant placement after several months later, we still needed to further perform minimal bone augmentation. So we needed to perform a little bit modification the position like this. And we also can have much more better bone gain at the crease site. Now we can, in this situation, if we perform implant placement, we don't need to perform any bone augmentation gain. So it's look excellent. However, there is a new issue arises. Look at this. The sharp edge of the shedding screw, it will irritates the mucosa. I will show some clinical case. Like this, after several months of healing, for some thin gingival biotin, the gingival mucosa is punctured by the sharp edge of the shedding screw. So we need to a slight modification for shedding screw. Now, because thanks to our grooved design, the second generation shedding screw is bendable. we can, as a clinical photos indicator, we can bend the head of the shedding screw before we transfer in the basal bone. And this area is not sharp enough, and it will not irritate the mucosa, so we are safe enough. And the next level, we have developed the third generation shedding screw in 2024. It's brand new design. Now, the first we have to change the shape from the circular to rectangle, the shape. It's much more adapted to the Alveolar ridge. Meanwhile, we also keep the bendable feature. And the supporting area has increased by 40% compared to previous generation. So here I'll give you some summary and review the evolution of the space maintaining devices in bone regeneration. The concept introduction by Marx in 2002, and the refinement of the technique by Ra and the compilation with GBR by Simon in 2015, and with the advanced space maintenance and the optimization and clinical application by Carville. And in 2024, I developed the shedding screw concept. It's brand new space maintenance. Now, I give you some clinical cases. In this case, with teeth missing in the posterior mandible, this teeth was extracted over 3 decades, and the average is obviously narrow and reception. So we need to perform bone augmentation. And then we took a CT scan. According the sagittal view, and we also virtually plan implants on the software, we can observe at the site 44, there's sufficient bone. However, in the 46 and 47, the implant, the back side of the implant, they have several threads that was exposed. Therefore, we need to perform bone augmentation at that area. Now, full thickness flap were elevated. We can observe the lateral Alveolar ridge, and then we perform osteotomy procedure. Now, as the white line indicates, this narrow. I'm sorry. The white line indicates is ideal bony envelope. However, the lateral bone is collapsed, and as the line shows, we needed to perform augmentation at that area. Then 3 implants were placed at the ideal position. Now, this is our augmentation area. We look at the back aspect. We can see clearly there's several threads was exposed. So we need to perform augmentation. And this case is unfavorable bone defect. You know, if we say the white color, I usually tell my colleagues, you need to drill several cortical perforations. You can see the fresh blood is slipping away from the cortical plate, but it's not enough. We need to correct autologous bone particles. Here is a bone augmentation area. Now, let's move on to the autologous bone harvesting procedure. This is the disposable script. It's also designed by myself. It's very sharp. I can use it to correct sufficient autologous bone particles within 10 minutes. And in this case, we have to correct zero graft mixed with correct autologous bone chips mixed with zero graft at the ratio 6:4. The next step is fixation of shedding screw. Now, the white line indicates the ideal bony envelope. So we twist three shedding screws in position, and we note that the gap is relatively wide, and we only use to put the fill up band material. Look at it. The contour is plump immediately. The next step, we put several to the one collagen membrane on top, along with several CGF membranes. Finally, optimal wound corrosion. This is the post-op CT scan. Now we can see from the sagittal view. Look at the yellow line indicates this angle is close to 90%. 90 degree. Is perfect. If we perform other technique, let's say the sausage technique, we will not have the so excellent angle. Because we have the shedding screw, it can provide a good simultaneous. And according the cross-section view, it also along with the ideal bony envelope. So I do go ahead. So I wait 6 months, and the patient come back. Now we can observe the thin gingival, and the shedding screw is showing through, but it's not exposed yet. We are safe enough. Next step, we need to take a CT scan to confirm the situation. Now, let me have a look at the sagittal view. You can look at around the implant, we have the adequate variable. We are more than 2 millimeters, so we are safe enough. And we can compare with the initial situation. So it's very good result. The next step is to remove the shedding screw. In this case, I perform the hybrid the incision design. At the buccal aspect, I perform partial thickness flap to remove or shedding screw. And at the crystal aspect, I decided to perform the full thickness flap to uncover the implant, like this. At the set for number 4-6, we even to use the ball rounder, the rounder damped ball to grind away the new bone and to uncover the implant. Let me have a look at a closer view. Look at this picture. It's very beautiful bone around the implant. The fresh blood sweeping away from the bone. So I feel very happy. Let me do a simple comparison. The right photo is the initial situation, and the left set is the initial situation, and the right set is actually post-op 6 months. Is big change. And the next step, we move on to soft tissue management. We know that the bone sets the tone, the soft tissue is the issue. So soft tissue management is equally important. In this case, we have the tuberosity graft from the palate, and then we split it into a long strap of FGG. Then we move the strap backwardly and use the lino suture to secure it. Between the gap, we use a collagen matrix to fill the gap and induce the soft tissue migration. And this is the post of the 2 months. We remove the healing cap. Now we can observe the excellent emergence profile, the beautiful soft tissue architecture. And this is a occlusal view. It compared with the initial situation, we have achieved a very beautiful outcome. And this is the final restoration. The delivery of final restoration, the soft tissue is healthy and is harmonious with the adjacent teeth. And this patient, he finally get his missing teeth back. She felt very happy, and as a clinician, I feel happy too, because I hope I can help the patient regain the missing teeth. Now, I'm going to show you another case. It's actually the same scenario, missing teeth in the posterior mandible. We can clearly see the significant contour collapse because the teeth all were extracted almost 10 years. The next step, we took CT scan to check the situation. And now, let me have a look at the cross-section view. I have drawn a red line. It indicates the ideal bony envelope. However, the lateral bone is occurred significantly bone resection. And let's move on to the sagittal view. We mentioned at site 35. At the crystal site, it's only 2 millimeters. And about the 3.6, we measure it is almost 4 millimeters. It's not enough. We need to perform bone augmentation. In my daily routine, I prefer to stage approach. However, in this case, I choose implant placement along with the bone augmentation because the patient live far away from my city, far away from Guangzhou, so we decided to perform one surgery. Now, full thickness flap was elevated to expose the lateral alveolar ridge. Now we need to perform execution, and we virtually planning the 2 implants would place at the ideal position. And now we can observe at the back aspect, there's not adequate bone. Therefore, we need to build up the missing bone, like the yellow box showed. Here, we move on to surgical procedure. In this case, we're using attached bone harvesting bore to correct. And this surgical kit is also designed by myself. I really love this kit because it's very sharp and it is effectively to correct adequate attached particles probably within 50 minutes. And we have enough bone chips. And this is the implantable placement at the ideal position. I don't want to place too deep, so I only place the depth is 4 millimeters far away from the gingival margin. And the next step, we twist the 2 shedding screws imbriquely, and between the gap, we fill up with the attached bone chips and compact it gently, make it a good adaptation. And we also cover with a collagen membrane on top. Finally, tension-free, we close the flap. We wait 6 months. So after 6 months later, the patient come back. Now we can observe the shedding screw is almost a little bit showing through, but we still safe because it's not exposed, so we don't worry about that situation. In some cases, we also encounter some exposure of the shedding screw, but because of the smallness of the surface, It's if the patient can keep good adhesion, we are still safe. You can remove the shedding screw after 2 months. If you can keep the shedding screw in position at least 3 months, you will have the excellent bone formation. You should don't worry about that. Okay, let me back this case. We took a CT scan. This is the 6 months post-op CT scan. We can observe that according the sagittal view, the bone, this good bone formation. We can have a look at the buccal aspect of around the implant. We have the more than 2 millimeters. And the next step, we need to remove the shedding screw along with the pseudoperiosteum. In this case, we also can get a clear view. We have the very good bone formation. The very rich become primary is wide enough. So I just gave a simple comparison. The post-op 6 months and this initial situation, this is a bigger transformation. We have the unbelievable result, all right? In terms of the volume, in terms of bone quality, we have the very, very good outcome. Now, we move on to another very interesting technique. We also call it the hammock technique. If some colleagues, you perform extensive bone defect, you perform large bone reconstruction. Let's say you twist several shedding screws. However, in some cases, you don't want to use so much shedding screw. You can use resorbable sutures and weave a net. It's just like a hammock. So we all call it the hammock technique. It's very interesting. Now I will show you some cases. In this case is actually performed by my colleagues because in anterior region the tooth 1-2 and the tooth 2-2 was missing for several years, so the control is significantly collapsed. Now, full segment flap, we can expose the average, and we use the around the broad to remove the periosteum completely. The leg step or twister, 4 shedding screws in position. Now, the leg step we weave on net. So it's a resolvable mesh. It can provide extensive simultaneous, and between the gap of fill up zero graft together with some a little bit attached bone particles. And then we place the large collagen membrane. Finally, tension-free occlusive flap. This is the procedure of this case. Now let's move on. Another case is about the vertical bone augmentation. Now it's performed by my team, Google Elite team, Dr. Liang. Now we can see this the posterior mandible. This huge vertical bone deficiency along with some a little bit horizontal bone defect. So we need to build up the missing bone. Now, we twist 2 shedding screw in position. Some of you guys may ask why you don't twist 3 shedding screws. In this case, we don't choose 3, but 2, because at the middle set, the native bone is not enough, and we fail to achieve primary stability. So we don't choose that approach. And between the gap, we use the resolvable sutures with a mesh, and it can provide a good specimen tennis during the healing. And between the gap, we free up biomaterials mixed with some autologous bone chips. And this is the post-op CT scan. This, you know why? Because this is severe vertical bone augmentation at the middle set. So we fail to transfer through shedding school. And we can say, according to the subtle view, we have the good adaptation, a good feeling, is excellent bone shape. Now we wait at least 6 months. And 6 months later, we re-enter. We can see the bone is very good bone formation. Even this new bone to cover the shedding school, I need to use a rounder dammed bone to grind away the new bone. It's very good. The next step, we need to remove the shedding school like this, and it also we can notice it. It's very thin through the periosity, and we can see the hole is a fresh blood sweeping away. It indicates a very good bone quality. Next step, two implants were placed in ideal 3D position. This is the case. Because with the limited time, I will not show you another cases. This case is performed by my team, co-created. The Dr. Nan. Dr. Nan had performed a lot of shedding schools, from single missing tooth to multiple teeth, even full arch bone extraction. It's amazing. So we also can achieve the predictable bone augmentation, meanwhile with less technical sensitive. So let me give you a brief summary of my presentation. If we want to achieve a predictable bone augmentation, we need to follow up the PACE principle. We need to keep in mind we have to achieve primarily with the healing, primarily with the coverage. We need to follow a genome analysis. In some cases, we need to correct adequate autologous bone chips. You can see I present several cases. I have usually to correct autologous particles. All right. And during the healing, we need to avoid any infection, no matter acute or chronic infection. And we also need to keep in mind the time is equally important. Last but not least, the space maintenance is always important, especially when we perform bone augmentation in the anterior region. So this is the PACE principle. And finally, have a good news for all of you. Our predictable bone augmentation 4-day workshop will take place in Guangzhou from October 14 to 17. This is an intensive immersive course from basic fundamentals to advanced skill sets. We will touch every details of bone augmentation, from in situ design, fragmentation-free suturing, autologous bone harvesting, and sticky bone preparation. We also will cover treatment planning, technique selection, from simple case to complex cases. Last but not least, we will further discuss the prevention and the management of the common complication, because we know how to deal with complications is also very important. If you are interested, don't miss out on this training. Save the date, October 14 to 17. Oh, this was my presentation. I thank you for your kind of listening. And if you have any questions, you can feel free to leave your question in the chat. And you also can follow my Instagram account or add my WhatsApp account. Welcome keep in touch with. Okay, I have finished.
Thank you, Dr. Lee. Thank you for your impressive presentation and your beautiful cases done by yourself and your team. And not only as a very great clinical practitioner, you're also an innovator who innovates so many specific instruments and the keys and the screws. Very interesting. Thank you. Very enlightening. Okay,
Thank,
so right now.
thank you. Thank you, very kind comments. It's my great honor to have to share my daily practice in the episode webinar series. If there is there some questions?
Oh yeah, there is a question the audience asked, how is the shielding screw different from the tenting screw? I think
Okay.
yeah.
Yeah, I've showed the pictures. Is actually I have the show in my slide. Probably you have missed out. Here we go. Hey, like this one. Can you see my screen?
Yeah, you're sharing
Okay.
your screen.
There is the difference. In currently in the market, there are two categories. One is umbrella screw, as the picture shows. It's a thick head. It's called. It's just like an umbrella, so it's called umbrella screw. In my daily practice, I have used some umbrella screw in my early practice, but I think it's not perfect. You know why? Because thick umbrella screw will take up all space when you perform bone augmentation, especially when you perform bone augmentation in the maxilla. You know that the tissue free is relatively difficult. So it will take up a lot of space. Let me switch to the tennis screw, the difference. You can see the tennis screw. It's a tiny head, so it cannot to provide the effectively the space maintenance. It's just like the in fact in literatures, I see a lot of the literatures they use the tenting screw. It's just like the microfixation screw. It's very tiny of the head, so the space maintenance is not work effectively. However, I've shown you the shedding screw. The video. Okay, you can see this is the brand new design. The shedding screw is much bigger head and it's relatively thin. It's only the thickness of the head is only 0.8 millimeters. It's very thin. And we also have specifically designed. We have the several holes in the head, so we also can use perform the hammock technique. You know that? We have to show you some very interesting case. We use a resolvable sutures to weave a net. It's a resolvable mesh, and it also can provide us a much more vascularization. We know that the vascularization between the periosteum and the bone graft is also equally important because we can have a better for bone maturation. Yep, this is the tenting screw. Compare
Okay.
the shedding screw is totally different. So it's a brand new specimen panel. Okay, that's my answer.
Okay, thank you. And the second question is about if the shielding screw is exposed or at 1 month follow-up, what will you do?
Okay, good question. I have mentioned that in my slide actually. I have the talk it in detail. If they, I'll show you. Yeah, like this clinical photos. If in some patient thin with thin gingival belt tab, you have high risk of the shedding screw or tennis screw exposure. But you can notice that from the picture, the surface is very smooth, so it can keep good adhesion. It's not easy to get an infection if the patient have good adhesion, and we need to keep at least, from clinical perspective, you keep at least 2 months. At 2 months later, you can remove the shedding screw. You only cut a tiny incision and it turns out. It's a very simple way. If you use another specimen, let's say the titanium mesh, if there's explosion, it's very difficult to manage. You need to cut a large incision to remove the titanium mesh. However, if you use the shedding screw, you only cut a tiny incision and it turns it out in a simple way. So it's easy to manage it. So after 2 months of later, you turns out the shedding screw, the bone graft is have a little bit stable. They have the capability to withstand the pressure from the muscle. So you have the majority of the bone formation. You only lose some a little bit bone. That's my question.
Okay. So what if the soft tissue is insufficient to cover bone graft, like insufficient to keratinize the tissue? So are you gonna do simultaneous soft tissue grafting or separate procedure?
Oh, sorry, I don't hear clear. Can you repeat it?
The question is about if there is insufficient or not enough soft tissue, not enough keratinized tissue to cover your graft area. Are you going to do soft tissue grafting and hard tissue grafting
Okay,
simultaneously or do
I
them
see.
separately?
I get your point. Okay, I see. Uh, I don't prefer at the same time. It's high risk. I only prefer one thing. Because you have to need to consider 2 factors. The soft tissue augmentation, you need to have perform a lot of time. Along with the bone augmentation, is a long time procedure, and altogether the time is very long. And the number 2, this the patient placement, and after 2 or 3 months later, after implant placement, I perform soft tissue augmentation or soft tissue procedure. That's my daily practice. Yeah,
Yeah.
I hope my answer is clear.
Yes, yes. And the last two questions are related. Um, like sometimes because of like the huge defect or insufficient soft tissue, it's a little bit difficult to get primary closure. And how will you deal with this problem, like by releasing periosteum, releasing, or to do some muscle pressure minimizing techniques to achieve the primary closure?
Okay, good question. It's actually focused on the P, the primary root coverage. If we perform bone augmentation in the mandible, it's relatively easy because we can perform release the buccal aspect along with the lingual aspect. Is in the majority cases, I think it's not a bigger issue. It can easy to achieve the tension free. The most difficult scenario is in the anterior maxilla because we can release tension in the palatal because this is cartilage tissue we can release. We can only cut periosteum in the buccal aspect to stretch the flap. But in majority case, in most of the case, I think it's not a big issue. You need to practice. You need to know how to step by step to cut the periosteum, to stretch the periosteum, and you need sometimes you need to know some data. You know that is it you need to check is it the tension is free or there's a little bit tension. This is very difficult for especially for the beginner. He don't know exactly whether this tension is free or have a little bit. And I think the most difficult scenario is the maxilla, the failed bone graft cases is very, very difficult. In this case, I think if you are the beginner, you need to refer your patient to some clinicians have the master can perform advanced bone augmentation. So you just refer your patient. Yeah.
Okay. Thank you. You also answered the question about the patient suffering systemic diseases and chronic inflammation. I think the indication and contraindication for whether for regular GBR or for the shielding screws GBR are actually the same. And the last question, there is a new one pop up. This is the last one. All right. Is it necessary to use a resorbable membrane with the shielding screw? Will you use them all the time together? Hello, Dr. Lee? Yeah.
Okay.
Yeah,
I can
yeah.
hear
Can you hear
you.
me?
Yeah,
Yeah, yeah.
yeah. So can you repeat the
Oh,
question? Because
sorry, maybe
yeah,
because I've lost my connection. Yeah, the question
yes,
is, when you are using the shielding screw, is it necessary to also use membrane?
yes.
Yes.
You that depends. If in some case we also because you fill up some bad material together with zero-gravity particles, we do cover collagen membrane. However, we are also have a trial. We do not use any membrane. The only one we collect 100% of touched bone particles or touched bone chips. We don't cover any collagen membrane, just cover CGF membrane or PIF membrane because it is follow the same principle of Curie technique. We just switch the bone place into the meta place. You just can imagine that scenario, which so we also can have achieved relatively predictable bone augmentation.
Okay. Actually, I also have a question for myself. Like when you
Oh,
are using the bendable screw, will you
mhm.
just bend the screw first before you place it on the bone, or you place the screw in the bone first and then bend it inside too? Which one
Okay.
would you prefer to do first?
I prefer bender first. You know why? If you place the shedding screw in position and you want to bend it, it's very difficult because there's
Yeah.
natural teeth. You will have the very hard to handle it. So this is my daily practice. I prefer to bend it first and then we transfer in position. Yes.
Okay. All right. Thank you, Dr. Lee, for your
You're
for answering
welcome
of these
for your
questions.
very nice moderator.
Okay, I think the audience may still have a question about how to buy or get access to your keys and your and your shielding screws. Yes. Okay,
Yes,
all right.
good. Okay,
So
all
you
right.
can maybe you can leave your QR code of your keys buying to